Thank you everybody for coming. It's really a pleasure to be here. I am depends what context you know me in. I'm either Rabbi Josh, Josh Sturm. You can call me whatever you want, just don't call me late for dinner. But it's a pleasure to be here and to be hosting this evening. I want to just give a little bit of a brief background. Everybody who's on this call is obviously very familiar with renewal. That's how your point of contact coming onto this call. And we'll hear a little bit more or a lot more as it comes about the PKD free organization and all of the different options that are available. But I just want to share with you very quickly how this whole thing came together. There's a gentleman on this call on the panelist side by the name of Richard Kellner. Richard, I hope I don't embarrass you by saying all of this, but I'm going to do it anyway because I have the mic. Richard is a wonderful individual. Richard called me up. Gosh, this goes back probably 11 years already, when renewal was in its earlier stages, and he wanted to share with me his experience as a kidney donor. He donated to his wonderful wife, and he wanted to share with me what his experiences were like as a kidney donor. And I was very eager and excited to hear his story, and it was a beautiful story. He called me back up a number of years later that unfortunately the kidney was not working, and subsequently she passed away, and she is forever remembered. And Richard decided that he's going to change the world. Really, that's what this is. And he said, no family should have to suffer from PKD anymore. We're going to try as best as possible to eradicate this illness from the face of the earth. And so we started this foundation, this organization, PKD Free, with the goal of educating families about the possibility of being able to prevent the next generation from having this illness and this disease. And to Richard's credit, they've already done a number of successful testing and implantation, and they'll talk more to the success. But Richard, you are a remarkable individual. On behalf of Mendy Reiner, our founder, and myself, when Richard presented this idea to Mendy about doing a joint program on this, Mendy jumped at it because he saw and understood the importance of it all. So thank you all for becoming educated tonight and learning what this process is. I know that this topic is a sensitive topic, and we are very mindful of the anonymity that many individuals that have this want to maintain, and that's why we did this format as a webinar. So as it's mentioned when you registered, your video is turned off, your audio is turned off, and the only thing that's visible is whatever name you put in, and you can feel free to change the name if you want to as well. And that's the way that we wanted to make everybody comfortable. But we also want you to be interactive in this forum. We're going to have time for question and answer towards the end of the session. And the way to ask a question is there's a Q&A button on the bottom of your screen. So I apologize to those that are call-in listeners. That won't work. But for those who are on the computer or on their phone using going through Zoom, you are able to type in a question. That question will come up to us on the panel, and then we'll start to answer some of those questions as the evening goes by. We'll do a question and answer session at the very end, and it's really the way to convey as much information as possible. I want to turn it over now to the president of Renewal, who is Sandy Ornstein. Sandy is the one who is able to really bring the vision of this idea of living kidney donation to fruition. With his uncanny vision for organizations, Sandy has started and runs many different organizations. Notably for this call is Premium Health, and Sandy's going to talk about that as well. But Sandy has been a gold mine of knowledge and information on an organizational level, helping Renewal to function and to get to the point where it is today. And for that, we are always indebted to him. And I'm going to turn it over to Sandy Ornstein, our president.
So thank you, Josh Sturm, Rabbi Sturm, however you call yourself. So my name is Sandy Ornstein. I am the president of Renewal. I am also the president and chairman of the board of Premium Health. Premium Health is an FQHC, a federally qualified health center, that one of its missions is in Dr. Josh Klein, who's on our screen, to as reproductive endocrinology to help treat the Jewish community when it comes to infertility. We facilitated thousands of IVF and other cycles, and I'll let Josh Klein talk. Because I wear both hats, I have seen the successes on both sides. On one hand, Premium Health help facilitate IVF and other treatments for clients who otherwise um, wouldn't want to and wouldn't know how and wouldn't be able to build families. On the other side, the renewal, we have facilitated a, where are we up to, Josh? Close to 1,400?
1,400. Thank God.
1,400 altruistic and family kidney transplants, and many of them were for a number of family members in the same family because they have genetic diseases. And we came to learn that when Richard Kellner called us and said, I have an idea, that will jump in that idea. So now we can bridge premium health and renewal and see if we can help the next generation of those unfortunate families able to build families without the risk associated with it. I just want to address for one moment those the Orthodox Jewish listeners that we have ran it by our rabbinical council for premium health. We got the green light to do this webinar and help Richard with this initiative. We encourage you all to ask your local rabbi, your advisor, whoever you speak to. But before you ask, this is why this webinar tonight is so important. When you ask advice, be an educated consumer. Make sure you know what you're asking. And that's why this webinar is important. Take notes, ask questions. So when you go to ask what to do next and get direction and get guidance, become educated. Thank you for listening, and you'll hear soon from the experts.
Thank you. We already heard from one expert, that's Sandy, but thank you so much, Sandy. But we are very privileged to have with us tonight Ms. Melanie Hardy, who is the Director of Research and Advocacy Initiatives at JScreen, which is an organization that does this kind of screening for genetic anomalies, mutations, all of these kind of things. And she's going to explain a lot about that. She has focused her efforts specifically in this area on community outreach, on education, which is so crucial, as you all understand. There's so much of a lack of education out there on these issues, and she's doing a wonderful job of getting the word out there, using her experience, her expertise in genetic counseling. Of course, she has many degrees. She's certified by the American Board of Genetic Counseling, and it's really just a privilege for us to be able to hear from her tonight. So I turn it over.
Wonderful. Thank you so much for having me. I'm really excited to talk to everybody here. Should I just share my screen?
Yeah, I gave you the
Okay.
ability.
All right, perfect. Um, okay. Everybody can see that okay? Yep. Okay. Yeah, so I'm very happy to talk to everyone about what I do and some provide a little bit of background information about genetic testing and how it applies to our conversation tonight. So we'll kind of start there, a little bit about genetic testing. First of all, in order to do genetic testing, we have to start with a sample. There's got to be some kind of cell information that we can use in the testing process, and we can get that typically through standard samples like a blood sample, saliva sample, or a buccal sample. All three of these use the same cell type. The big difference between these is that there's a higher volume of DNA in a blood sample than there is in a saliva or a buccal sample. So there's typically a lower recollection rate when we do a blood sample. But importantly, we can get DNA samples, cell samples from many other areas of the body. So we can use amniotic fluid, we can use a skin punch, and we can even sample from embryos. So there's lots of different ways to get the raw material that we need to be able to do genetic testing. Once we have that sample, we have to look at the genetics of what's inside. So within the cell, there is the nucleus, and inside are all of the genes. We have two full copies of DNA, two full sets of genes in every cell. One is from the egg cell that made us, and one set is from the sperm cell that made us. Genetic testing is going to analyze both of those copies and look for variations, look for differences in the way that it's structured. So because genes really are the blueprint for the body's function, when a gene has a variant or a mutation, then that means the gene's not doing its job, and often it means the body can't function normally, causing disease. And there are a lot of different genetic conditions that we're able to test through various different types of genetic testing. This is just a handful of different types, and I kind of divided them in this table based on how they're inherited, or the mechanisms, patterns of inheritance behind each. So we can kind of categorize different conditions based on either how they're inherited, how they sort of operate. And I'm going to highlight specifically two that are primarily applicable to this crowd: autosomal recessive polycystic kidney disease and autosomal dominant polycystic kidney disease. So I'll use those as examples. When we talk about autosomal recessive inheritance, um, we are most concerned when both parents are carriers of the same disease. And what that means is that of those two gene copies that they have related to this particular condition, one of them is affected. It has a variant or a mutation, a change that causes that gene copy not to work. The other one's there. It's fine. It's structured the way it's supposed to, and it can do its job. In a recessive condition, one gene is enough to keep the person healthy. But when we start looking at all the various ways that this couple, both of them carriers of the same condition, pass on their chromosomes, we see that about 25% of their pregnancies are going to be completely free of disease, no variants, no mutations in those genes. About 50% of their pregnancies are going to be carriers like the parents, and about 25% are going to inherit both of the gene copies that are not working appropriately, and those can cause disease. So ARPKD is one example of how this works. When we look at dominant inheritance, ADPKD, for example, one gene variant is enough to cause symptoms. So usually in these cases, we might see one affected parent. And when we look at all the various ways that those two parents can pass on their genes, we see that it's a 50% chance in any given pregnancy that they would have a child affected like the parent who is affected. The other thing to kind of know about these two conditions, again, using them as sort of an example here, is they can look very similar in how the symptoms arise. So we might see a little bit earlier onset with ARPKD. This can impair lung development, so we can see some slight difference there. But both of them, if a person is affected, genetically speaking, if they have the disease, then 100% of those individuals will develop disease. There can be variation in how it expresses itself. So the age of onset, liver disease progression, there are different things about how it shows itself in that person that can differ, but that also makes it sometimes very difficult to set these two apart. And that's where genetic testing can come into play, because as you'll see, at the bottom of the slide, the genes behind these two conditions are different. So by doing genetic testing, sometimes we can sort things out. Another question that may come up is, who should consider genetic testing? And the answer is, it sort of depends on a lot of different factors. Genetic testing can be helpful for reproductive planning. So if people want to know if they and their partner carry the same condition and or might have a chance of having a child affected by a condition, they can do carrier screening. If a person wants to know more about whether they're affected with a condition or um, the mechanics behind their diagnosis, there's genetic testing for those individuals as well. Sometimes people just want to know if they might develop disease at some point in the future, and that's where like having a family history of a condition might lead that person to test. So you don't have to have symptoms in order to pursue genetic testing yourself. But depending on what time in their life, what a person wants to know, genetic testing may be valuable for different people for a variety of reasons. Um, Another thing to think about is sometimes we see conditions in otherwise disease-free families. And the question comes up, why? Isn't this an inherited condition? Why might we see disease in one person and not have a family history of it? And that can occur for a lot of reasons. There might be a small family size. Might have limited information about prior generations, or sometimes families just don't talk about these things. We can also see brand new mutations popping up in one individual. So we might not always have a clear family history of disease. And again, that's where genetic testing in a person can still be very beneficial. So I'll close just by talking a little bit about the company I work for, JScreen, and what we do. We have two different products that people are that are available to people who are interested in genetic testing. One is reproductive carrier screening. So we have a panel of over 260 conditions. It's used for reproductive planning. We typically test people between ages 18 and 45, and we are interested in testing women, men from any ethnic background, and we can test across the US. Our hereditary cancer test is the other test panel that we have. We currently test over 60 different cancer risk genes. This we typically will test over the age of 25. Again, women, men, any ethnic background doesn't matter, and still available in all 50 states. Now you'll notice in this list, we don't test for ADPKD, but we do test for 13 different genes associated with cancers that impact the kidneys. We do test for 50 plus conditions associated with kidney disease on our reproductive carrier screen. So we do have a lot of impact on the kidneys and in our various tests. And if you do test with us, this is what you would expect. You can request a kit at jscreen.org. We send a saliva kit by mail. You collect your sample and return it in a prepaid mailer, and then the lab processes that sample and you get results via telehealth. So we have an entire genetic counseling team. I'm one of them, where we can talk to patients about their results by phone or video across the US. And this is my contact information if you want to know a little bit more or you want to visit our website to see what we do.
Thank you very much. Really a pleasure and very informative. So we're going to move now to Dr. Joshua Klein. Dr. Klein has I mean, just look on his background over there. You can see all the diplomas and all the awards and special recognitions. He is a wonderful thing. But I will just say about Dr. Klein, first of all, again, I have the mic so I can embarrass whoever I want. He is above all, a term that the listeners on here will understand. He is above all a mensch. He's really just a genuinely real solid good person, and he does a lot. He is the reproductive endocrinologist. He's the chief clinical officer at Extend Fertility. He'll talk a little bit probably about that. He's the co-founder of an embryology lab as well. He does so many things, and as Sandy said, on the board of Premium, and really just involved in a very significant way over there at Premium Health. Dr. Klein has tremendous knowledge, and even though I have the mic, I'm embarrassing him too much, so I'm going to stop with all of the accolades. But Dr. Klein, it's all yours.
Thank you very, very much. It's
Do you
my
want me to share the slides, or you want to do it from yourself?
why don't you do it actually? Because I don't trust my technical skills. Um, I'll just say it's my pleasure and honor to be part of this panel. So thank you for asking me to speak. Thank you to Rabbi Josh. Thank you to Sandy. It's really been an amazing partnership. All of the work that we've been able to do together at Premium, and God willing, we should continue to grow and to achieve good things. You know, when I was asked about doing a webinar about PKD, so it turns out this is actually a true story, and I think I told this to Rabbi Josh initially, but I'll never forget when I started practicing fertility medicine. Literally, my very first patient of like my very first day after doing, medical school and residency and fellowship training. It's a very long path, literally almost 15 years of training. My first patient ever was a young couple in their 20s who basically came to me after having had a baby. And it was a devastating story. The baby was born with PKD, and it was an autosomal dominant case. And the baby passed after a few weeks of life. And they were referred to my practice to talk about doing IVF and PGTM. And so PKD, there are a lot of genetic conditions, unfortunately, that people struggle with, and thank God that we can help them manage using IVF and genetic testing, as we'll describe. But certainly PKD holds a special place in my heart, and so it's just a little bit of a coming full circle to be presenting at this on this panel. So with that introduction, so what I want to cover very briefly, and this is geared towards just giving an overview. There's a lot more to say than we'll cover in this quick segment. But first, just to define what is IVF with PGTM, a lot of letters. Second, how does it work? And there's sort of three main stages of the process that I'm going to walk you through. Third is, how do you think about success rates? Does it always work, or do we need to be worried, that it's not going to work if I go down this road? And then lastly, a little bit of commentary on risks, limitations, and costs. So next slide. So what is IVF with PGTM? So first of all, IVF stands for in vitro fertilization. It is basically the technology that was developed at the end of the 1970s. So now it's new, but not that new in the world. It's been around for 40 plus years. And it's the idea that we can take egg cells out of a woman's body and combine them with sperm cells in a laboratory to create fertilized eggs, or what we call embryos. And typically we're doing that with more than one egg and more than one sperm at a time. And that's why most of the time, as we'll talk through, we're talking about a bunch of eggs and a bunch of embryos. And by doing so, that enables the idea of PGTM. So PGTM stands for pre-implantation genetic testing for monogenic disorders. The reason there's so many letters there, well, actually, let me start with pre-implantation genetic testing. Pre-implantation implies pre, like before, implantation, before we take an embryo and return it back to a woman's womb, to a woman's body, to help her conceive with that embryo. We're doing genetic testing for one of many possible reasons. And PGTM, as opposed to other forms of PGT, specifically refers to a situation where we're looking for a known monogenic disorder. Mono means one, and genic is like gene. It's referring to a condition that is attributable to one specific gene, and PKD is, of course, one good example of that type of scenario. But there's hundreds of monogenic disorders, and that's what Melanie was talking about earlier, that when we do reproductive carrier screening, we can look to see if the potential parents carry any one of hundreds of monogenic disorders, PKD being just one of them. Now, I also wanted to insert on this slide that one of the practical issues with IVF and PGTM is that every PKD family or patient has its own unique version of the gene, and therefore the test for that gene will have to be customized to their version of the gene mutation. The term that's used for that is called a probe. And so one of the steps in the process that we're going to walk through is probe development, meaning the genetics lab needs to specifically create a test that is customized to that particular patient. Okay, so how does IVF with PGTM work? So to begin with, the parents need to undergo the IVF process to create embryos. That part of the process is very similar, if not the same, to any couple who's doing IVF for any one of the usual reasons, the most common being fertility problems. And that's actually why I put on the slide there, parents should avoid natural pregnancy, because usually in the context of IVF, there's an issue where the parents are not able to conceive easily. In the case of IVF with PGTM, like PKD, there's no reason to think that the parents would have any trouble conceiving. And if they want to go down this road and do IVF with genetic testing to avoid the risk of having a child with PKD, then it sometimes can be forgotten. But they should not only be thinking about IVF, but they should be using contraception, perhaps again in the setting of a religious couple, in consultation with their rabbi, what approach, but essentially to be doing something to avoid natural pregnancy before and while they're going through the IVF process. Once the IVF happens, a few cells are removed from each embryo in the lab. Those cells represent, or they contain, a representative sample of the genetic makeup of the DNA of each embryo. So as Melanie said earlier in the conversation, some of the embryos will get the gene and some of them will not. And so the IVF process is not fixing the gene, right? We cannot take the gene away. That's something that maybe down the road with newer research might be eventually something we could do. But today, an embryo that has the gene has the gene. But what we're doing is identifying, when we have numerous embryos, we're identifying which embryos have the gene and which not. So the DNA from those cells is analyzed for the mutation, and then eventually healthy embryos, which are either unaffected at all or carrier embryos potentially that have the gene, but they're only carriers, they're not going to be affected by the disease, are then chosen to be returned to the womb. Okay, next slide. So to dig a little bit deeper into the way IVF works, there's sort of 3 stages. That's how I usually present it to patients who are trying to kind of wrap their heads around the process. The first stage is preparation. It gets its own stage because it usually takes a significant amount of time, and there's some legwork that needs to be done, as we're going to go through step by step. Second is what we call the stimulation cycle. That's the main part of IVF that people usually think of when they're talking about IVF, with hormone injections and a procedure, as we'll explain. And the third part, and hopefully the best part, is the transfer cycle. Once we have a healthy embryo, the way that we return that embryo to the body to create pregnancy. So stage 1, preparation. And I wrote all IVF because these steps are, again, common to anyone who's doing IVF, regardless of the reason. Typically, the process begins with an appointment with a consultation with a fertility doctor, formerly were called reproductive endocrinologists, to kind of discuss the details of their specific situation. There's going to be a whole bunch of blood work that needs to be accomplished. A lot of it is required for any IVF, infectious disease testing, some hormonal testing. There's a bunch of paperwork that needs to be addressed, consent forms, medical consent forms, very common. Semen analysis. So IVF always requires, even in a case such as this, where there's no specific concern for fertility problems, this is not an infertility situation, meaning the couple has no reason to think that they can't get pregnant easily on their own. The lab, the IVF lab, prepares differently if it expects the sperm that they're going to get to work with to be more or less healthy. So all labs are going to ask for a semen analysis to be completed before the actual IVF is done as part of the preparation. One of the common things that are specific to religious patients, it's not obligated, and again, you should certainly consult with your own rabbi, but in order to minimize the amount of times that a man needs to produce a sample for a sperm sample, what we can do is combine a semen analysis with a sperm cryopreservation, which basically means that in advance of the IVF, the man just needs to bring a sperm sample once, the lab records how healthy it looks, and they freeze it to save it for use. If it's a healthy sample, that's the only sample that we're going to need, and that whole situation is accomplished in one day. Now, there's a whole other conversation again in the Jewish and religious world around the approach to how to collect a sperm sample. I'm not going to get into that unless people want to, I guess, afterwards, but we'll leave it as there are ways that religious Jewish patients collect sperm samples, And it's definitely something that you'll want to consult with a rabbi about what would be advisable for your situation. Also, part of the preparation phase is a class to teach the patients about how to use the medications they're going to need for IVF. As many of you probably know, the medications that cause the eggs to grow, which is the primary job of the medication, do not come in pill form. They only are available as small little needle injections. So there's a lot of injections for IVF. The needles are very tiny, and it's usually not something that people ultimately think is too terrible. But we do need to prepare people in advance that they're going to be using these medications via injection and teach them about the medicines they're going to use and how to use them. Now, more specific to IVF with PGTM as part of the preparation. So one thing is expanded genetic screening, and Melanie obviously covered that. Dura Yesharim is a whole other topic. It's generally more limited in terms of the genetic screening than something like J-screen would be. Consultation with a genetics counselor and or the genetic testing lab. So it's crucial that in the process of preparing for IVF, the couple has a clear understanding of what the gene they have is, what the risks that are conferred by the presence of that gene, and any specific concerns or considerations with the ability to test for that gene. So that's something that, again, typically will happen by discussing with a genetics counselor in conjunction with the genetic testing lab that develops the probe for the genetic test. And then probe development. Probe development can take a long time. It can take usually minimally a few weeks, and sometimes it takes a few months. And very rarely, the lab will have trouble developing an appropriate probe. So usually we encourage our patients who are doing IVF for PGTM to initiate that process of consulting with the genetics lab and having them start the probe development pretty much as soon as they can after the consultation, because oftentimes that's going to be the step that has the slowest lead time, the longest lag time. And the sooner you get started on that, the more quickly you can move on to the actual IVF. Okay, so that was all stage one, all the preparation. Once all that's done, we can move on to stage two, which is what people usually think of as the actual IVF or the stimulation cycle. In this graphic, I think it summarizes very simply what the stimulation cycle requires is typically about 10 to 14 days of hormone injections. The job of those medicines is to get multiple eggs to grow. When we do IVF, we don't want to just take one egg at a time because, as we'll talk about, a lot of the eggs won't cooperate. They may not fertilize when you put them together with sperm. They may not develop into embryos. And some of the embryos are probably going to be genetically unhealthy. And so the approach is to get as many eggs as we can safely get at once so that at the end of the day, after some of them don't work for this reason, some of them don't work for that reason, we have a good chance of having at least one and hopefully more than one healthy embryo to work with when the dust settles at the end of the process. So it's about 10 to 14 days of medications to get those eggs to grow. There's what we call monitoring. Monitoring means blood work and ultrasounds that we use to be able to see the effect of the medicine. Is it working well? Should we change the dose? Should we change the approach? Are the eggs growing quickly or are they growing more slowly? Different people have a different response to the medication. Once the eggs have finished growing, there's a procedure which takes about 15 minutes and is done with anesthesia called an egg retrieval. And then once the eggs are retrieved, taken out of the body, they're combined with sperm in the lab for fertilization. So we'll go to the next slide. I'll try to run through this pretty quickly because it's just a little bit more detail about the stage two. So usually an IVF process starts with the beginning of a menstrual cycle, but depending on if someone's using birth control, that might be a little bit different. So it's something that would be discussed with the clinic, with the doctor's office. As I said, 10 to 14 nights of injections. It's usually more than one injection each night. And then we have those monitoring appointments, usually about every other day during those week and a half to 2 weeks of the medications. Then you get to the procedure. When the eggs have finished growing, the procedure itself is done with ultrasound guidance and a needle. So there's no cut, there's no incision, there's no stitches, there's no scar. It's not a real surgery in that sense. We're not cutting someone open to take the eggs out. It's basically a very thin, long needle that passes through the skin of the vaginal area directly into the ovary to remove the eggs that have grown. And it takes about 10, 15, maybe 20 minutes. Rarely is it 20 minutes. It's done with anesthesia so people don't feel anything or remember anything from the procedure itself. And they are able to walk out the door from the procedure usually within about 45 minutes to an hour after we're done. Once that procedure is done, the action moves into the lab under the microscope. And basically, on the day of the procedure, we can find the eggs that have been retrieved. ICSI is an acronym that's used for the process of combining eggs with sperm. The day after the procedure, we can see of the eggs that we have how many of them combine normally with the sperm, called a fertilization check. And then after 5 to 7 days of growth in the lab, the embryos are developed and ready to be biopsied, and then the embryos are frozen. So we need to save all of the embryos in order to allow for the time for the embryo testing to occur. And that means that basically at the end of a week after the procedure, whether we have 5 embryos or 10 embryos or more or less, they're all frozen without knowing which are the healthy ones, which not. And then usually a couple weeks later, the genetics lab will send us the information, the test results. Okay, of the embryos that you have, how many of those are healthy, usable embryos? Okay, next slide. Once we have at least one healthy embryo, and hopefully more than one, as we'll discuss briefly in a moment, we can move on to the last stage, which is the transfer cycle. A transfer cycle is often referred to as a frozen embryo transfer, or FET. It typically takes about 3 weeks of some monitoring and some medication until the transfer procedure. It's usually much easier than the stimulation cycle in stage 2. Stage 3, the medication is mostly pills, and the monitoring is less intensive. It's not every other day. It's usually about once or maybe twice a week. And then the transfer procedure itself does not require anesthesia. It's not a surgical procedure at all. There's no needles. It takes about 10 minutes, and we use a little plastic catheter to essentially deliver the embryo that we have already known or found to be healthy, to deliver it through the natural opening in the cervix back into the womb, back into the uterus. And that's it. And then we wait typically 9 days after the embryo is delivered into the uterus. We can check to see if it actually successfully implanted and if the patient is pregnant. So the overall timeline, this is what we usually tell people, from the day that a patient walks in the door to talk about doing this until they could be pregnant with a healthy pregnancy, is usually at least 3 months. 6 months is already on the longer side, but usually not less than about 3 months from start to finish, even if things go, straight line, everything's going smoothly. So it is a process that takes time. Okay, now briefly about success rates. So one thing I want to point out is that it depends on how you're thinking about success rates. Does PGTM, this technology of testing embryos, is it successful in the sense of, does it tell us the right answers? So the answer to that is it's not 100%, but it's close. It's something in the neighborhood of 98, 99% accurate. And so for the most part, if a couple does go down the road of IVF and PGTM, and then we transfer an embryo that has been tested and known not to have the gene, let's say for PKD, they can feel very, very confident, like 99% confident, that testing is going to be accurate. Ultimately, the recommendation is still to consider confirmatory testing during pregnancy, like amniocentesis, so that 99% can be 100%. But again, PGTM is very highly accurate. So when people talk about success of IVF in this context, where things aren't nearly perfect, it's not but the PGTM reliability. It's more regarding the idea that IVF in general is an imperfect process, because not every egg leads to an embryo, and not every embryo leads to a pregnancy. And the main drivers of whether IVF will be successful are going to be the age of the woman and her, what we call ovarian reserve, or her egg supply. And basically what that refers to, without getting too far into the general ideas of IVF success, is that if we have a patient who is a woman in her 20s, usually the vast majority of her eggs are healthy because she's young. And usually she is a very robust, a very high egg supply because she's young. And so we can get 20 or 30 or 40 eggs at a time. And the vast majority of those are generally healthy. And so the likelihood that we can get at least one, and hopefully more than one, healthy embryo from in that context is very, very high. Whereas a woman who's in her 40s, let's say a woman who either got married late or for whatever reason is trying to grow her family in her 40s, a woman in her 40s, most of her eggs are not healthy anymore because of her age. And usually her egg supply is low. And so we might not be able to get more than 3 or 4 or 5 eggs at a time. And so it becomes like a double problem. If you don't get a lot of eggs and most of the eggs that you get are not healthy, it can be very, very difficult to find healthy embryos when the dust settles. So the graph for those who see the visual here, the graph on the right is just a general sense of how successful IVF can be in general. Forget PGTM, any IVF. And the idea is that for women in their young 30s or younger, the chance of success per try usually is in the neighborhood of about 50%. So not 100, but pretty good. Whereas women in their 40s, it can be 10% or less. So age and egg supply are the two main drivers of whether we get healthy embryos and whether we have a good chance of achieving pregnancy. And this graphic is not very, very important, but it sort of reflects the general idea that you start out with a certain number of eggs. The eggs have to be something called mature, which I won't deal with right now, but that's another detail. And then the eggs have to fertilize when you combine them with sperm. And the fertilized eggs have to become embryos, and the embryos have to be genetically tested and be healthy. And then even the healthy embryo has to implant. And the idea is that you start off with a lot, and at every step, some get lost. And so that is the challenge with IVF, is to have enough healthy embryos standing at the end of that funnel, because we know that there's so many steps that have to be done. And again, for younger patients, there's a very high chance they'll have not just one, but multiple healthy embryos. For older patients, it can be much more difficult. I do want to point out one more thing, which is that it is typically our goal to help patients, if things go well, to have multiple healthy embryos come out of their IVF. And again, that's usually something that's very much realistic for patients in their 20s or early 30s. It gets much harder for older patients, because the idea is that if someone does an IVF cycle and they create 5 healthy embryos, if they use one today to have a baby, the other 4 can stay frozen in storage and can be used in the future to expand the family without having to go through the entire process all over again. So stage 1 and stage 2 are kind of taken care of, and you just have to do stage 3, which is the sort of easier and less expensive and just generally quicker and simpler part of the process. So it certainly is the case that we're always trying to get a patient as much as they can get out of one IVF. And when things go well, especially for younger patients, it's not unusual that we could get enough embryos to have at least 2 or 3 or 4 children from the same IVF over the course of several years. Okay, last couple of comments, risks and limitations. So in general, IVF, there's some risk of any medical process that involves injections and a procedure, but the risks of IVF are very, very low. There's a minority of women who will have some side effects of the medications, and there's a rare risk of a complication from the procedure, like extra bleeding or an infection. These things are definitely things that we always mention, but thank God they're pretty minimal in terms of how they impact people's ability to achieve success. People often ask if biopsying the embryos by taking a little piece of them to do the genetic test is harmful to the embryo. And that's been studied carefully and basically proven that if you do it the right way, it should not impact the embryo at all. And then the main risk, as I've been kind of alluding to just in the last couple of minutes, is that what if we don't get enough healthy eggs to make enough healthy embryos to be able to be successful? And that risk will vary widely depending on the context. That's the type of thing that you're going to want to discuss with a doctor based on your age, based on your test results. Are they expecting you to get a lot of eggs and a lot of embryos and to have a very high likelihood of success or not? So I think that's the last slide that I prepared. It's probably more than I should have said, but oh, sorry, not the last. Cost. So cost is a big challenge in the world of IVF, and actually the existence of Premium Health and all the work that Sendi's done with his team there has really been driven at trying to help drive down some of these costs. But to give people a general idea of what things cost in the overall world, there's multiple layers of cost. Doing the development of the probe usually will cost at least $3,000, $4,000, $5,000, $6,000. The actual IVF will usually cost in the neighborhood of about $15,000 or more. The medications for IVF will cost several $1,000s. And then the storage of healthy embryos, if you do have multiple embryos to store for the future, is usually between $1,000 and $2,000 a year. Thankfully, because IVF and PGTM is sort of a medical condition, commercial insurance will often, but not always, cover IVF with PGTM. Generally, Medicaid does not cover IVF, even if it's a purely medical situation. And that's a big reason why Premium Health has been so helpful for patients who do have Medicaid, to try to control the costs and enable patients to have children and grow their family in a healthy way. Okay, I think that's the last slide, if I'm not mistaken.
Thank you so much, Dr. Klein. That is, you managed to take a very complicated topic and really explain it in a way that even I could understand. So that's very impressive.
Thank you so much.
We very much appreciate it. So we're going to move now to our next speaker, Kevin Schnurr. So Kevin's coming at this from multiple perspectives, and I think that his experience really frames his area of expertise and his knowledge, because Kevin happens to be somebody who has or has had one of these genetic mutations. In this case, we're talking about Alport syndrome, similar. And Kevin, thank God, received a living donor kidney transplant, and you'll see him; he's doing wonderfully well. And from then, Kevin made it his mission to also help to change the world, starting with the Alport Syndrome Foundation, and now moving on in more recent times, in the last year, as the new Chief Implementation and Operations Officer at the PKD Free Alliance. I think that his experience, his life experience, really frames his mission and what he is all about. So, Kevin, please.
Um, as you mentioned, Josh, I have a personal connection to kidney disease in that I am the recipient of a living donor. As it turns out, Josh, I also had genetic testing, which is an important but separate piece of everything we're talking about tonight. And in addition to Alport, I also have a PKD2 variant of uncertain significance. So I actually am somewhat rare in that regard, that I have not one but two technical mutated genes. But for today's purposes, we're largely talk about PKD. So today, let's talk a little bit about why we're here, who we are, and the mission of PKD Free Alliance. Apologies to them for technology getting in the way here. So PKD Free Alliance is a New York-based 501c3 nonprofit. As we said earlier today, Richard's mission, this important mission that we started about 3 years ago, was to make sure we are empowering and educating patients so they have all the necessary knowledge to make decisions about using proven approaches, as we learned tonight, to prevent PKD and other hereditary conditions from being passed down to future generations. So this technology is tremendously powerful. It is transformative. And we speak every day to patients whose lives are improved by this tremendous technology. So what do? We provide qualified PKD families with not only the grant funding, but in many cases discounts to some top fertility centers nationwide for pre-implantation genetic testing, or PGTM, as we learned earlier, and in vitro fertilization, IVF, so that we can make sure that these patients are able to make decisions about whether or not they would like this disease to not be passed on to the next generation of children. And if it's not passed on and they have a healthy PKD-free baby, we don't have to worry about this disease going on for further generations. As you noted earlier this evening, Josh, the organization was started by Richard, who's joining us this evening in 2022. So what is PKD? PKD. I have a little overview here. I've also included a graphic courtesy of Mayo Clinic. A lot of folks don't understand what physically happens to the kidneys in the instance of polycystic kidney disease. I'll share, Josh, that as an Alport patient, my kidneys actually shrivel to scar tissue. So they're actually the size of about grapes or cherries. In PKD, it is very much the opposite. These kidneys grow to contain fluid-filled cysts, and the actual volume of the kidney size increases and increases. This naturally leads to damage to the kidneys, and that in many instances, these kidneys have to be removed, even in the instance of having a successful kidney transplant. So I'm not going to bore everyone with the science that we heard a little bit earlier, but it is important to remember some of these percentages. The dominant form of PKD, which is about 90% of cases, does have a 50% chance of inheritance if one parent carries this gene mutation. The recessive form, which is a rarer but more lethal and aggressive form, has a 25% chance of inheritance if both parents carry the gene mutation. So, unfortunately, like many other kidney diseases, There are no cures, cure singular plural, for PKD. There is one FDA-approved treatment. So many patients can do things such as making dietary changes and being on things such as blood pressure medications. And these can hopefully slow the disease progression and improve quality of life. But unfortunately, many patients do go on to experience ESRD or kidney failure and require therapy in the form of dialysis and or kidney transplant. So as we discussed earlier, IVF with PGTM is the only way in the instance of polycystic kidney disease to ensure that a child will be born free of PKD. Thank you again, Dr. Klein, for an excellent patient-friendly overview of all the steps in that process. So we'll move forward to our grant program, which is the reason we're really here tonight, is to discuss Richard's efforts to make this science, this assisted reproductive technology, much more accessible to families. As was mentioned earlier this evening, the cost for this entire process can be a lot, especially for young families, which is precisely why we're here to help. So the Alliance provides PKD impacted families with grants ranging from $3,000, which would cover that pre-implantation genetic testing, all the way up to $9,000 for qualified patients, which would cover both the PGTM and IVF treatments. And as you can see on the slide here, we also are aligned with genetics companies and fertility providers who are able to provide additional discounts for those who have gone through and been approved for our grant program. In addition to this, I'm excited to say tonight that the Alliance is open to supporting families that have other hereditary kidney diseases other than PKD on a case-by-case basis. So these individuals would potentially be eligible for our PGTM grant. So if you're listening to this webinar this evening and you find yourself with a hereditary kidney disease other than PKD, and are interested if PKD Free Alliance could potentially help you offset the cost of that PGTM, we encourage you to email us at helpingfamilies@pkdfree.org. We'll also provide some contact details in a slide further on. Success stories. So since July of 2023, we have received over 200 grant applications, which is tremendous. And we provide support to well over 100 families on their PKD-free journey. We've welcomed 20 free PKD babies to the world to date. We have some cute pictures here. We have funding in place to support 300 families. And this fall, we're making the ambitious ask of our community to help us reach funding to support 500 families through our year-end campaign, which will be starting next week. We have over 30 medical centers, fertility clinics, genetic companies, and advocacy organizations in the kidney space that are completely aligned with our mission to stop PKD from being passed on to future generations. I have a list here of some key medical centers supporting our mission. These include Ferguson, Columbia, University of Utah Health, University of Miami Katz Family Division of Nephrology and Hypertension. And thank you to Dr. Han, who is here from Columbia on tonight's webinar. We've been very fortunate to get a lot of media attention on some of our families who have gone through this process and have had a happy, healthy, PKD-free baby, have been spotlighted on local media outlets throughout the country. One of our greatest supporters here is Justin Zanuck. He is the GM for NBA's Utah Jazz, and Justin himself is a PKD patient. He received the gift of life in the form of a kidney transplant through a paired kidney exchange in April of 2024. We were very fortunate to Mr. Zanuck for, during a broadcast of an NBA game, mentioning Richard and mentioning the Alliance by name and letting the world know a little bit about this technology and how this disease, PKD, has affected his family. So we appreciate the Zanuck family for their support and spreading the word about our efforts. Here I have a little bit about ways to get in contact with the Alliance. So we have our website, pkdfree.org. Our email that I mentioned earlier, helpingfamilies@pkdfree.org, will be answered by either myself or Melina, who's joining us this evening. We're also on all of your typical social media channels. We encourage you to reach out however is best for you, and we would love to speak with you about the potential of helping you to either not pass on PKD or potentially not pass on another hereditary renal condition in your family. Thank you all for having me, and I apologize again for the Zoom snafu.
No problem. Thank you so much, Kevin. Really very informative. And as Kevin mentioned, we are very privileged to have Dr. Han with us here tonight. Dr. Han is an amazing doctor who deals with many of our PKD patients. He's based out of Columbia University, and has a close relationship with many of our patients, and they speak worlds about him, and really a wonderful individual. And I'm going to start the questions off actually just by asking Dr. Han, um, a patient that has PKD and receives a new kidney. I know we're talking about PKD free here, but just a question that does come up. Is there any chance that their new kidneys can be affected by that PKD?
Yeah, hey Josh. Thanks once first for inviting me and having me on this platform. And to answer that question, I'm a straight shooter. So there's zero chance that the new donated kidney, so the allograft, will be impacted by the underlying polycystic kidney disease. The interesting fact, I think that is also commonly asked for related to kidney transplant and polycystic kidney disease, is that oftentimes after 1 year after receiving kidney transplant, the existing native polycystic kidneys reduce in size by 50%. So, I think it was common practice back in the days to remove the kidney sometimes when it was causing problems, when it was causing a lot of symptoms. But more studies now show that even removing the kidneys are not necessarily required because of that reduction.
Thank you. So let's go to our some of our questions. And again, I encourage you, if you have questions, type them into the Q&A, and we'll get to them hopefully. So the first question is, and I guess this goes to probably to Dr. Klein, can PGTM be done on a frozen embryo?
So I guess that thank you. That probably refers to the idea that embryos that have previously been created, and now the idea is to do PGTM at this point. So the basic answer is yes, it can be done. The idea is that we would unfreeze the embryo, do the biopsy, and then refreeze the embryo to find and wait till we find out if it's healthy or not. In a perfect world, we like to do it up front, meaning at the time of the original embryo creation. But if someone has embryos that are already in existence and they do want to do genetic testing on those embryos, it usually can be done, yes.
Okay. Another question is that this is really for Kevin and Melina. Obviously, we have a very diverse background of our patients, and many of our patients are coming from families that are having, God willing, many, many kids. The question is the PKD Free Alliance able to help with the funding? Is there a limit for how many testings that they'll do?
No, Josh, there's not.
That's a great answer. We love those answers. And power to you. I mean, it's amazing stuff. Melina, anything you wanted to add on that?
Yeah, so with the hope that, you go through PGTM testing, there is the hope that you get many PKD free or not genetically affected embryos that are chromosomally normal, which would only require one cycle. But thankfully, we are able to provide multiple fundings in the case that multiple cycles are needed.
Awesome. And of course, in terms of the funding in general about IVF, everybody's encouraged to reach out to either their local organization. Certainly, Renewal can be a resource to help guide people towards different ideas of where to go, because the costs do very much vary from place to place. Dr. Klein gave us some the financial part over there, which seems to be very, very good. Sandy, anything you want to weigh in on that?
So if Premium has a partnership with Extend, so to oversimplify it, in an IVF procedure, there's the let's call it pre and the actual retrieval and transfer and the post. A lot of the pre and post testing can be done in Premium. So those that live in Brooklyn don't have to go to Manhattan, and that is covered by Medicaid. And then the medication, we have a pharmacy called the 340B pharmacy, which is a government-funded pharmacy. So that's a huge cost. Is also mostly covered by New York State Medicaid. So if you look at a package of numbers of $18,000, $19,000, if you go through Premium, through Extend, Dr. Klein, what would be the savings?
Yeah, I mean, it probably cuts between the monitoring and the testing and the medication. You're probably eliminating about 40% of the overall cost of the process by going through the premium system. I think that's fair to say. So it's a
And also,
huge
and you get Dr. Klein. When you get it, if you live here, you get it locally in the community in a state-of-the-art center, so you don't have to. It gives you that advantage as well. And if you want a little more information, who would they reach out to, Dr. Klein?
I'm not sure.
I mean, they can
Our division.
certainly reach out to us, and then we'll
You know
find
what?
out the right
Reach out to
contact.
renewal. Is it going to be Tim or Toby? Who would be the best person to?
Probably Toby, but we can provide that.
I'll do this offline with Josh. So they'll
Cindy,
reach out to renewal, and we'll figure out the
are
next.
there any options financially for people living in Jersey or other parts of the country?
Not yet, but Dr. Klein and I are working on it. We're very close as we speak. Very close does not mean tomorrow. Not
Okay.
before a year. But
Okay.
we're on it. We had tremendous successes in the last few months.
Okay, our next question I think is for Dr. Hahn, and the question is, can PKD be lived with without needing a new kidney, even though there's a family history of it?
Yeah, so that's a great question. I think Melanie touched on it very briefly. So although PKD is a monogenic condition with very, very high penetrance. So if you have a gene mutation, that one gene, there's a very, very good chance that you will have the disease manifests in you. However, she also mentioned there's a lot of heterogeneity amongst the family, even with this among this family, same family members. So even with that same gene mutation, there's many different manifestations. And and what that really means is, and this is one of the researches that we've done at Columbia, is that although PKD is a monogenic condition, its progression is likely determined by polygenic factors. So there's a lot of different gene interactions that happen that actually determines how fast somebody progresses with polycystic kidney disease. So I truly believe that the answer is a definitive um, or or very hopeful yes. The lifestyle choices that we make and learned through patient empowerment, patient education really matters. Because I do believe that there is a lot of different manifestation of it. And one family member may require dialysis initiation at age 50, but another family member may never require dialysis or transplant.
Dr. Hahn, as a follow-up to that, if
Mm,
a person has the PKD gene,
mm.
when do you recommend, at what age do you recommend that they start regularly seeing a nephrologist?
Yes, that's a great question. So in terms of seeing a nephrologist, that means, it also comes with medical management, recommendation for lifestyle changes. And earlier the better is what I would say if the patient is determined to have the gene mutation, right? I think, um, although, as Kevin mentioned, there's currently only one FDA approved treatment for polycystic kidney disease, unfortunately. I think the couple of the questions down the line, maybe I can also help answer that question. I truly believe we are living in a different generation than our predecessors with management of polycystic kidney disease, even starting with something great as PGTM being available for our patients. It's a real option. And at the end of all my patients' clinic visits, and I go through a whole slideshow of what is PKD, the one thing that most of the couples ask me is, what about my kids? What about my kids, right? So just the fact that this option is available now to end PKD is something that is huge. But in addition to this, there are more drugs that are being developed. They're being developed, more clinical trials. We're actually starting one up in Colombia pretty soon that are targeting much, much more upstream, where the mutation actually occurs and or where it's actually targeting the mutated protein. So to hopefully tie these two questions together, I really do think that there is hope for PKD on the horizon, whether through more knowledge and patient empowerment through lifestyle modification, which, to answer your second question, should be done as early as possible. And second, there are other drug developments and more opportunities like PGTM that can help to curb the future of PKD.
Would you recommend even pediatrics?
So pediatrics, that's a great question. There's that one medication that has now been looked into the pediatric population to see if there's benefit in that population. As far as I'm aware, in terms of the new clinical trials that are coming up, those new drugs are not particularly targeting the pediatric population yet. However, the lifestyle modification does matter. So um, earlier PKD is identified, earlier it can be managed.
So just to be clear, families that have this gene, you would recommend that even the kids get tested for to see if they have it as well.
If that's within the family's wishes. However, the one thing of note, as we know, genetic testing, there are some protections against for medical insurances, and I'm sure Melanie can definitely speak more into this as well. But there are other concerns such as life insurances that we do have to be cognizant before just openly testing everyone. So I think this is really much more of a discussion, much more of a nuanced discussion with the patient and the parents.
Melanie, you have anything you want to add on that?
Yeah, I think it's important to know what Dr. Han was sort of referencing is a 2008 federal law of GINA. It's the Genetic Information Non-Discrimination Act, which protects against use of genetic information to discriminate against individuals based on employment decisions. So like they can't be fired because they test positive or health insurance. And there are a few nuances to that, but generally speaking, those are protected. Things that are not protected by GINA, but can be protected at the state level, depending on where a person lives, are life insurance, long-term care insurance, and disability insurance.
Would you know most of the people on this call are New York, New Jersey? Would you happen to know the details on those particular states? I'm
To my
putting you on the spot, if you
knowledge,
know.
they don't have much for protection, but I really am not an expert specific to
Okay.
those states. The one state that interestingly has really great protections is Florida.
Wow. Okay, the next question is for Dr. Klein. So the question is, how does IVF work if the man is the one who has the PKD gene?
So the answer is the same. The process of the IVF, getting the eggs, getting the sperm, putting them together, make the embryos is the same. And the genetic testing, I don't think there's, I mean, other than perhaps some detailed ramification for how the genetic testing lab looks at the details of the genetic testing. But otherwise, basically, the main answer is it is the same regardless of whether the mother or the father carries the gene.
Okay, next, again for Dr. Klein, what happens if all the embryos in the cycle test positive for PKD? How many cycles can you continue to keep going?
So yeah, I mean it's an important question because the answer is that can happen. As I was sort of saying during the session, the more eggs we get, the more embryos we get, the less likely that is to happen, but it can happen. We definitely have patients who do multiple cycles. There's no medical limitation on the number of cycles that a patient can do. We have patients who do 3, 4, 5, 6, 7, 8, 9 IVFs. Not that many, but and again, it's not what anybody wants, but it is medically an option. It just gets really difficult because it's very much a draining process on all levels, physically, emotionally, financially, and so forth. But yeah, if someone does a cycle and does not get any healthy embryos, they absolutely can cycle more than once again.
And
Said
in
one,
terms
two,
of
three,
many
four.
people have, oh,
At one point, he said someone do 1, 2, 3 for 6, 7. What's considered a lot of cycles?
Anything more than 3, 4 is already a lot. I mean, to do one is a lot. That's the truth. And so patients, it's not rare that patients maybe do 2 or 3 or 4, but once you're getting past that, that's a lot. And again, to be clear, not that it's a lot like we get worried that it's dangerous for them per se, because medically we don't think that it has an impact in any significant or long-term type of way. But like I said, it's just a lot because it takes a lot of time, effort, resources to get through it.
I'm sorry, Josh. I want to continue this conversation. So
please.
somebody that wants to put away, they want to have 4 or 5, I'm not sure, 5, 6 embryos. Would they do the cycles back to back, or they would spread it over a 10-year period, like they would do and wait, get pregnant, do it again, or just, do as many as you can, as young as you can, and
It's always a conversation. Yeah, that's a question that comes up pretty regularly, especially in the Orthodox world, patients who are hoping to have a larger family. At the end of the day, there's no doubt that, as I kind of alluded to earlier, female age is the number one most powerful factor with regard to how many healthy eggs and therefore how many healthy embryos we get. And so in isolation, the idea would be that patients who are doing it now should do multiple cycles to bank as many embryos as they can, as young as they can, before they start using them. And technically, that's not wrong. But at the same time, a couple who has no children yet, for them to spend the next 2 years doing IVF over and over and over again before they're able to have one child for life reasons may not be the right choice for them. And so, we usually have that kind of conversation of what would be the target for how many healthy embryos will give you peace of mind that for the next X number of years and X number of babies, you're kind of in good shape. And you may or may not want to do IVF again in the future. You don't wait till you're 40 to think about it again. So it's something that you can revisit every couple of years. But it's really a personal choice based on the couple's mindset and tolerance for, how willing to be patient they are, how large of a family realistically are they trying to achieve, what resources are available to them to be able to do IVF altogether, those type of considerations.
Is a pregnancy that goes through IVF any different than a normal pregnancy?
For the most part, no. There are people who advocate that every IVF pregnancy should go to a high-risk obstetrician. I don't know that personally. I think that's necessary. So bottom line is that overall, the pregnancy, once they achieve pregnancy, there aren't meaningful differences in the obstetric care.
And as I think a lot of people on this call are perhaps a little bit new to the IVF idea, as I understand it, it has changed over the years, meaning you're not implanting as many embryos as in the past. Can you just speak to that?
Yeah, the simple idea there is that in the older days of IVF, it just didn't work as well. And so, 30, 40 years ago, if we had one embryo and we would transfer it alone, the chance of pregnancy might only be 10 or 15%. And so in that context, it became quite common, quite normal to be transferring 2 or 3 or 4 at a time, because we'd be lucky if even one of them takes, and the risk of all of them taking together would be super low. Today, if you have one healthy embryo, we see pregnancy rates in the neighborhood of 60, 70% for each one. And so there's no reason that we need to throw in 2 or 3 at a time to achieve a good chance of pregnancy. Plus, if we do that, then we're really rolling the dice as far as twins or triplets, which obviously is not considered medically the healthiest way for a woman to carry. So that's been the evolution of the field generally, is away from, well, in the good direction or in a good way. The better success rates have allowed us to be transferring fewer embryos at a time. That leads to healthier pregnancies in general.
Okay, this next question is I think for Kevin and Melina, and also for Dr. Klein. Is it possible to access these options if one is not living in the United States? Are they able to come and get any of these benefits? Can they sign up with Extend, with PKD free? What can we talk about?
Sure, Josh, that's a great question. So our PGTM program is open to those in the 50 US states and also to our friends in Canada. Despite having what many perceive to be a better healthcare system, perhaps than here in the United States, PGTM is unfortunately often not covered. So for folks without insurance for PGTM in both the 50 continental US states and in Canada, they're eligible for our PGTM grant. Our IVF grant, which is the expanded grant containing PGTM and IVF up to $9,000, is only available for those in the 50 US states at this time.
Awesome. Dr. Klein, and Extend will.
Yeah, I don't have much to add. We're certainly happy to try to take care of anyone who's interested in having us help with them. So it's not, our care is certainly not geographically limited. Realistically, it can be difficult because, as we went through earlier, the process involves a lot of visits. And so there are ways that patients who live at a distance from their primary care team, they can do some of the ultrasounds or blood work locally and only come for part of the process. It's a conversation that we can have with patients who live far from where we are. So bottom line is that they certainly can come. If they can be in town for a couple of weeks to do IVF, then that makes it definitely doable. If not, we can try to find ways to make it work with a more limited amount of time locally.
Nice. And Sandy, premium can work with anybody?
New York State only.
Okay, New York State only. Thank you. For now.
For now.
Okay, Melanie, there's a question. Can J-screen test kids?
So we don't test anyone under the age of 18. The goal with our testing is either for reproductive planning purposes or for personal health, like looking at cancer risk. So the populations that we're interested in testing are all adult populations.
Thank you. Dr. Klein, is there an age limit for IVF?
There's a loose age limit, so not a limit on the young end, as long as the woman is an adult. But on the higher end, we really worry that for patients who are over age 45, the chance of getting healthy eggs and healthy embryos becomes so vanishingly small that it becomes difficult for us to, really put a patient through the whole process with the chance of success so low. So usually around age 45 is when we start to encourage patients to consider other options and that IVF doesn't make sense for them.
If they have frozen embryos from earlier, is there an age limit on implantation?
So that changes the ball game completely. So if patients have embryos from previous or eggs, unfertilized eggs frozen from previous, generally for an overall healthy woman, she could use those frozen materials for sure up to age 50, 50 to 55 with kind of special clearance from a high risk OB. After age 55 makes us all a little uncomfortable, but certainly at age 50 is almost a given, and 55 is usually the kind of where people start getting uncomfortable.
Okay, the next question, I guess, is for, I'm not sure, maybe everybody. The babies that are born through this process of only implanting those that do not have the PKD gene, and Dr. Klein, as you said, it's not 100%, but close to 100%. Do they retest these babies when they're actually after they're born to see if they have the gene?
Well, what I know, and I mentioned during my little segment, is that it is encouraged for the pregnant woman to have testing like an amniocentesis done that would confirm the results of the PGT testing. But
And
then the babies, I
amniocentesis
don't get to see the babies usually, so anyone else can jump in on that one.
Dr. Han, you want to weigh in?
I don't see babies either. I see mostly adult patients. Yeah,
The amniocentesis, is that 100%?
That is considered diagnostic, meaning definitive, yes.
Okay. Okay, looks like another question over here. How much does it cost for genetic testing to find out if somebody with a family history of PKD is carrying the gene? So if somebody wants to do just genetic testing to see if they are a carrier, does anybody have insight into what those cost? I know, Melanie, you mentioned you don't do specifically PKD, but perhaps you'd have some insight.
I mean, I can tell you about the pricing for our testing. So if somebody were looking at, reproductive planning, for example, and wanted to test for AR-PKD, that's on our panel. The way that JScreen testing works is there's an upfront program fee of $49, and then the patient can decide to either do a self-pay price of $249, or they can elect to use insurance. And for the reproductive test, most insurers do cover that. And the lab does the billing. They communicate with the patient what their out-of-pocket would be. And if it happens to be higher than the self-pay rate, the patient gets the choice of switching to the self-pay rate instead. But most people will pay less than $100 out of pocket for reproductive carrier screening.
yeah.
Awesome. Okay,
I,
next
I
question
can
was,
also
yeah.
So I can just add in just a cent or dime to this general PKD genetic testing. So definitely the most common panel that is used clinically is a panel through Natera. Is called Venusight. But I have never had a patient with insurance pay for. At least that's what the company tells me. So it is very widely available, and we just do it in clinic. It takes about 4 to 6 weeks for the results to come back. So it is much more widely available than initially thought. And then second, if it is out of pocket, I think as Molly noted, even for that testing, it's about 250 to 300 out of pocket. So it is much more accessible to the patients.
Dr. Han, I think this one would be for
Mm.
you. The question is
Yes.
if the mother, or I guess address both, it really probably doesn't make a difference, but if one of them has PKD, are there statistics on how many, I know it's 50-50, does that carry all the way through on a large family, let's say, how many kids will have that gene?
I think Melanie can certainly help answer this, but I would say statistically, it is 50-50 if it's due to the autosomal dominant inheritance pattern.
Melanie, anything to add?
Yeah, I mean, you would kind of think of it sort of like a coin flip in each pregnancy. So each
Mm.
pregnancy, it's a 50-50 chance. And if you imagine yourself sort of flipping a coin multiple times, approximately 50% of the time you're going to land on heads versus tails. Of course, you can have much more of one, much more of another. So sometimes we do see a skewing in large families, especially outside of that 50-50 range, but generally speaking, it should be around that.
But the skewing, there's
Yeah.
no rhyme or reason to it. It's just,
The,
chance.
PGTM can change the percentage to 0.
Absolutely.
Nice,
Yep.
nice. Okay, yeah, the skewing is just divine providence, we'll call it. But like Dr. Hahn said, getting it to 0 is the goal.
Yeah.
I think that is the last of the questions. Richard, is there anything you wanted to come on and say?
You know what, Josh? This is a full circle moment for me. I came to renewal in need of help for my late wife, Joe. You guys were there to help. Unfortunately, she didn't get that opportunity. But renewal at the end of the day, the model was really my inspiration for PKD for PKD free. So to be able to come back and offer this to your community and have it promoted in the community and the potential to eliminate PKD in a single community is what we're all about. So we're just very excited to have this happen, and this is the beginning of a bright future. And let's again, I've my family, like all of the other families on this call, we've been suffering with it for generation after generation. And the potential to allow our future generations not to have to think about it is what keeps me going.
Thank you so much. I think we actually have one more question I think is a very important question. And that is maybe for Melanie or for Dr. Hahn. How many people with the gene, the PKD gene, actually have it materialize and become really polycystic kidney disease? Is it 100%? Does it automatically happen?
Go ahead, Melody.
Oh, okay. So generally when we think of ADPKD, we expect that if somebody has the gene that causes it, the variant in the gene that causes it, that person will eventually develop symptoms. Now, there can be variations in age of onset and the kinds of symptoms that arise and how severe they may be. Some people they would develop symptoms if they lived long enough. So occasionally there are other factors that can impact whether symptoms arise. But generally, we do expect that they would be symptomatic at some point.
I definitely echo that. It is a very high penetrance, meaning if you have the mutation, you will have the condition.
But having the condition, as you said before, there is hopefully hope on the horizon of slowing or perhaps one day even curing it. And Dr. Hahn and I were speaking before everybody came on, and we shared the sentiment that we both want to be out of business. We'll figure
Yeah,
out what we can do instead. We'll have to go into something else, but
yeah, that's our goal.
we want to be out of business. Let's end PKD. Let's God willing, we pray that God should heal everybody, and there should be no need for renewal as well. So that is ultimately our goal. I want to just take the opportunity, especially to thank all of our presenters who did a wonderful job of really explaining what I think is a difficult subject to explain, and really to convey it in a way that was easy to understand and just very open and awesome. And I really want to thank especially all of our attendees. I know that it's not necessarily easy to explore this topic. I think for people that have it or don't have it or just want to know more, there's a variety of people who are on this call, but especially for those that this affects and impacts personally, I know how difficult that could be to try and learn more about it and to understand more. But a tremendous thank you to all of you